the diagnostic challenges that we face in recurrent disc herniation. So already, as has been covered, failed back syndrome, a whole lot of causes, including post-operative infection, implant slippages, disc herniations at other levels, and what we are discussing right now, that is recurrent disc herniation, which constitutes approximately 5 to 11% of these cases. Now, the important reason why we need to identify this recurrent disc herniation as a cause of the failed back syndrome is that these are patients where a repeat surgery can still give you a very good final clinical outcome compared to other causes like epidural fibrosis, where a repeat surgery will not really help you much. The annulotomy is the site or most of the times the cause of the recurrent disc herniation, and the risk factors have already been covered. Young male patients, smokers, and early return to post-operative activity, especially sports and weight bearing. So when we come to imaging, a plain and contrast enhanced MRI will remain the modality of choice for the evaluation of these post-operative patients. We can apply the metal artifact reduction sequences, which are different for different machines, but these do help to reduce the artifacts, especially if there are implants in situ. So that is one thing that we can add. And then when we look at the sequences, so you will be doing the routine T1, T2, STIR and GRE sequences. But very importantly, we will be adding the post-contrast T1 fat saturated sequences for the evaluation of these patients. Now here there is one caveat. When there are implants in situ, many times the fat saturation either does not work, or if you do it, the artifacts actually increase. So there may be a scenario where a radiologist may choose not to do the fat saturation in a post-contrast sequence in a post-operative spine. So what are the challenges that we face? So first of all, because there is a post-operative scenario, the anatomy is altered. We are having artifacts from the implants. There is edema and blood in the operative bed, which will hamper the imaging evaluation. Secondly, the imaging appearances are variable. That depends upon the time interval from the index surgery. So what happens is, over a period of time, everything evolves. So in case of epidural scar, initially it will be very bright on T2 weighted images, and as more and more time goes by, it will start becoming darker and T2 hypo-intense. Similarly, a disc herniation in the initial phase will have no enhancement at all. But later on, there will be a peripheral rind of enhancement, which is due to the granulation tissue forming around that disc fragment. So therefore, the imaging appearances are not constant, they vary with time. And lastly, the other complications like post-operative infection or a hematoma or a CSF collection, they look quite different. But disc herniation versus a epidural scar many times have confounding and overlapping imaging appearances, and this is what we need to differentiate, because one has a different way of management, a repeat surgery, which can give you a good final clinical outcome, while the other one, a surgery will not really help much. So how do we identify a recurrent disc herniation? So these are the 5 hallmark signs that we look for in a patient where we suspect a recurrent disc herniation. So it will appear as a well-defined ovoid soft tissue, typically located ventral or ventrolateral to the thecal sac. It will be iso-intense to the parent disc. Now in this case, because it's an operative level, the parent disc is likely to be degenerated, desiccated, and therefore this is likely to be hypo-intense on the T2 weighted images. Thirdly, if you can demonstrate the continuity with the parent disc, this will really solve most of the issues. The enhancement pattern, either it will have no enhancement or it may later have a rim enhancement. And lastly, it will have mass effect on the adjoining structures, the thecal sac or the nerve root, whichever is abutting that recurrent disc fragment. So this is an example of a recurrent disc herniation. So you see that is the disc fragment, a disc protrusion. That is the annular tear, the annular defect from which this fragment has come out. And you can clearly see that it is sort of compressing on that traversing nerve root in the left lateral recess. So this is the classical example of a recurrent disc herniation, a large blob of disc material lying in the right lateral recess. Here you can clearly see it has the same signal as the parent disc, and also it has the continuity with the parent disc. And on the post-contrast imaging, this is the typical rim enhancement that a recurrent disc fragment will show. This is the laminotomy defect, and you can see the enhancing epidural scar in that laminotomy defect, and this is the recurrent disc fragment. So another example of a recurrent disc, so wide laminectomy defect, a large blob of disc material, again same signal as the parent disc, continuity with the parent disc, and you can see that this is again causing bilateral lateral recess stenosis along with the facet arthropathy and impingement of the bilateral traversing nerve roots. So comparing that with epidural fibrosis, so if you look on now at this T1 weighted image, here it is very much has the same appearance, a blob of soft tissue in the left lateral recess. But when you look at it in more detail, you will realize that this is not just this blob of soft tissue, there is a whole ill-defined plaque-like area which is going around the thecal sac along the left lateral aspect, which is typically the side of the laminotomy. Now on the T2 weighted image, you see the signal, it is not the same as the disc, it is quite bright on T2 weighted image. So you see this area which is corresponding to this T1 dark area, this area is quite bright on T2 weighted image, and this is the post contrast. We have not done the fat side because there were metal artifacts coming from here which was hampering evaluation. So this is the post contrast sequence, and here you can see that same blob of tissue is actually homogeneously enhancing, and it is actually encasing that nerve root, that is the traversing nerve root. So it is not really displacing or compressing the nerve root, but rather just going all around it like a plaque and completely encasing that nerve root. So these two images will clearly help to differentiate what initially maybe look like a recurrent disc. Another classical example of epidural fibrosis, so homogeneously enhancing plaque-like tissue with the encasement of that nerve roots. So you can see the encased nerve roots within that, which again is a classical feature of epidural fibrosis. So to summarize, if you have to differentiate these two, recurrent disc, well-defined, ovoid or globular. Epidural fibrosis more likely to be ill-defined, plaque-like and irregular. Recurrent disc will have a same signal as the parent disc, typically hypo-intense on T2. This will have variable signal, T2 bright initially to becoming T2 dark later. Continuity with the parent disc, a hallmark of recurrent disc, will not be seen with epidural fibrosis. Enhancement pattern, which really helps us most of the times, rim enhancement or no enhancement, diffuse homogeneous enhancement, and mass effect, compression of the nerve root, while this will just go around and encase the nerve root.